I'm Suzanne James. Thank you for joining us. Having your rights and wishes respected in a healthcare setting can be difficult at the best of times, but particularly so in areas of medicine that are considered ethically challenging. Voluntary assisted dying, also known as VAD, is definitely one of those areas of healthcare. VAD is now legal all over Australia except the Northern Territory and has been available in Victoria since 2019 to terminally ill patients who are deemed eligible and for adults only. There are still quite a few myths and misconceptions around voluntary assisted dying, and unfortunately, also, there's sometimes misinformation published about it. To help us dispel some of that, today we'll be joined by Dr. Nick Carr. Nick is a Cambridge-trained GP. He's a senior clinical lecturer at Melbourne University and one of the first doctors in Victoria to train to provide VAD end-of-life care. He's also on the board of Dying with Dignity Victoria and kindly joins us from Melbourne today. Nick Carr, welcome.
Oh, Suzanne, thank you very much for having me on.
One of the primary things that's often raised whenever VAD is discussed and debated is the perceived risk of coercion. Now, those of us familiar with the legislation know that it is literally impossible for coercion to happen. There's not only a number of safeguards in place, but every year the various VAD review boards and health departments in the state of origin do a forensic blow-by-blow review of every single VAD case, and none of those reports have ever found a single case of coercion anywhere in the country. Nonetheless, there's still a common concept that it could somehow be possible, despite the fact that applicants go through a number of sets of hands and have to jump through a number of hoops before final approval. Just for the benefit of those normal people that don't probably read legislation in their spare time like we do, step us through that process, please, Nick. How many sets of hands does it go through, and how exactly does that detect or prevent any issues around coercion, say by a greedy relative, or perhaps, as is sometimes raised by domestic violence groups, a coercive or violent spouse?
Yeah, and it obviously seems a reasonable fear that greedy relatives will be dragging their elderly down to get them bumped off so they can get the loot. But if you know the process, that's virtually impossible. So the first thing is what's called a first request, where someone has to say to a health practitioner, I would like to consider voluntary assisted dying. And then there are three formal assessments by two different people. So there's the coordinating assessment, which is a long process to take the initial details. There's the consulting assessment done by a separate specialist, and then the so-called written declaration, which is done not just in front of the coordinating doctor, but also in the presence of two independent other adult witnesses. So you've got numbers of people involved. And the idea that you could get someone to agree to do this, to sign the documents, to say over and over again, yes, this is what I want to do, when it's not their choice, actually is ludicrous because the safeguards are huge.
Despite that, we often still hear stories when we do advocate work of family members that are very resistant to the idea that a loved one would have actually voluntarily signed up for voluntary assisted dying. And I appreciate that it's hard for family members to let go of loved ones, but how do you deal with that? What's been your experience with families, and how do you deal with that at the bedside with issues of patient care and confidentiality?
It's actually a really good point, Suzanne. And part of this is that if there is coercion, it's often the other way around. It's often family members saying, I don't want you to do this, not dragging them down there to do it, but trying to oppose it. So this is, again, part of the very long process that we do when we do an assessment for voluntary assisted dying. We do ask people about the attitudes of family and close friends and so on. These days, in my experience, most people are supportive. But of course, there are times when there are members of the family who are not. And I've been through this. I had one woman who was determined to go through the process, was well supported by her two sons, but she had a daughter who not only had a mental illness herself, but was a medical practitioner and a staunch Catholic. And she was very opposed to mum going through this process. How do we handle that? What it took was a number of conversations with not just mum, with the brothers, but with that particular daughter to help her understand whatever her views were, her mum's views were different. And in the end, she begrudgingly accepted that what mum wanted was right for mum. So mostly in my experience, people can understand and come around to the other way of thinking.
Now, we've talked about the safeguards. The safeguards are so stringent that many of the independent review reports have pointed out that some of them are so onerous they're causing equity of access issues. And your own organisation, Dying with Dignity Victoria, put out a press release on Monday pointing out 4 Commonwealth interventions that are required to help ease some of those. One of those is in relation to telehealth. Now, for those not familiar, there's 2 small paragraphs in the Commonwealth Criminal Code written long before voluntary assisted dying, or the current trench at least, was available in all the states and now the ACT, which say that it is a Commonwealth offence under the Commonwealth Criminal Code to use a carriage service, which is telephone or internet, regulated by the federal government, to do telehealth consultations, because it relies on the previous and now antiquated definition of VAD as suicide, which of course it isn't now under state-based laws. Now, you yourself took this to the federal court in 2023, I believe, and a judge unfortunately agreed with that assessment, that it is unfortunately an anomaly created by the new laws which could allow doctors to be prosecuted. Kate Chaney, an independent MP from WA, actually put up a telehealth amendment bill last year, which for reasons I'm still not clear on, the government chose to ignore, and it's now expired, and she'd already done all the legwork and administration for them. So why do you think the government hasn't fixed that particular aspect, Nick? Because it does have, unlike the government right now, an 80% approval rating, and they're heading into an election, and they keep telling us how concerned they are about remote and rural health issues. So why hasn't it been done?
It's such a great question. And this goes back right to the start of voluntary assisted dying in 2019, when the law came into effect. And we wrote to Christian Porter, who was then the Attorney General, and he didn't want to engage at all. Michaelia Cash took over. We finally got a response from her. She told us that she wasn't going to address this issue. And when Mark Dreyfus became Attorney General, we thought, well, we're probably going to get more luck with him. Unfortunately, for some reason, he also chose not to engage in the issue, which is why, in the end, we launched the legal action. And quite why he feels the need to ignore this issue, or in fact oppose it in the federal court, is a mystery to me. It was so disappointing in the federal court, because the argument was a very dry argument about the dictionary definition of suicide. And of course, if you go by a dictionary definition, choosing to swallow a poison to end your life is suicide. But we understand that suicide, as we think of it in the health sense, is a completely different experience to voluntary assisted dying. But so far, for some reason, the government hasn't shown any appetite to change this, despite, as you've pointed out yourself, Suzanne, public approval and support for voluntary assisted dying running 70 to 80%. You'd think it must be a vote winner.
You would think so, yes. And I understand from leading advocates, especially in Victoria and South Australia, Mark Butler, who's the Minister for Health and Aged Care, and also the Federal Attorney General, Mark Dreyfus, as you say, have been made very well aware of this issue. For some mysterious reason, have chose to ignore it. So anybody listening today who feels it should be addressed and wants to make it an election issue, as Dying with Dignity Victoria now has, I suggest you contact your federal MP and ask them for an explanation.
And if I may say, Suzanne, I mean, one of the things that people get concerned about, well, can you do that assessment properly through telehealth, which is actually a very reasonable question. No one's suggesting we do the whole of voluntary assisted dying care by telehealth. That's not the point. The point is that voluntary assisted dying is now a health option, just like everything else. And we've shown that we can use telehealth for all sorts of extremely complex and sensitive issues. We could use it as part of what we need for voluntary assisted dying. It's not that it should replace seeing people face to face. It just should be an option where it's appropriate. That's all we're asking.
And the federal law is now quite discriminatory in a number of ways. It discounts a lot of people in rural and regional areas, and indeed disabled people as a separate issue who aren't mobile or have difficulty with logistics and transport, who would otherwise be deemed eligible, not because of their disability, but because of their term.
I had a man who did a 12-hour round trip to come and have a conversation with me about voluntary assisted dying. It was the most extraordinarily onerous thing for him to have to do, but he couldn't have that conversation with me by telephone. So he took that huge long trip up to Melbourne to see me and then back again just to have a conversation about it.
Not only that, at least he was in a position to do that and to be able to find a specialist or doctor to see in many rural and remote areas that's simply not available. Okay, I'd like to talk to you now about the personal toll this kind of work takes on you and your family. You've been dealing with VAD families and applicants for many years now, and not apart from the obviously quite onerous professional development requirements and the administrative load and the extra costs and the practice ramifications. How do you personally deal with these situations, and what are the support services they have in place to support VAD doctors such as yourself?
It was one of the things that really concerned me before I started doing this work. How would I manage it? Of course, this is a totally new area for all of us. And I was asked the question when the law was implemented, when it comes to a practitioner administration, you having to go and give the medication to someone, essentially to kill them, to end their life for them, how will you feel? And my answer was, I have absolutely no idea how I will feel. I just hope I'm brave enough to cross that bridge when I get there. Now we've been doing this work for nearly 6 years. I think the experience of all of us who've been working in this area has been really a surprise by how extraordinarily rewarding the work is. I've never worked in an area of medicine where you develop this close bond with patients in just a few consultations. It is quite extraordinary. It's so personal, it's so intimate, it's so important. And it matters so much to people. And the patients themselves, the relatives, are so grateful for the work that you do that I found it astonishingly rewarding. It's probably the most rewarding work I've ever done in medicine, and that's saying something, I can tell you. And of course, it is difficult. There are times when I've come away from seeing a younger person, particularly, who's had horrible illness, and I've watched them die. And that is so distressing. On the other hand, I have to remind myself they were going to die. They had a horrible illness, and I helped them at the end to die more comfortably. So it is tough sometimes. We're very well supported, which is very good. We have a wonderful service called the Navigator Service, and they are a great avenue for support for people who need it. We also have the community of practice, the group of doctors involved in this, and they're also a superb resource when we're struggling with any questions or needing some help. And then, of course, there's always the wife and the dog at home.
Now, you've been around for a long time in various capacities. You're a regular on Australian TV, television, and radio. Everybody knows who you are. What do you say to people who, now they've listened to you today and they understand that coercion isn't even a thing, that it's legal everywhere except in Northern Territory, which hopefully will soon be taking steps to address that? What do you say to people who still feel it's their right to oppose it when it's probably not them that's going to some stage require it, an terminal illness?
I would absolutely support and approve of someone's right to say it's not for me personally. And everyone should have that right. And I would never try and cross that line. But just as I would never stop someone else saying it's not something that's right for me or my relatives, whoever it is, I do not want people telling me and my other patients what's right for them. This is such an individual question. And I firmly believe there is no one right answer. There are people for whom it isn't the right choice. That's fine. That's their prerogative. But do not tell the other people who are suffering who would choose this, you can't have it. And in the end, let's remember that here in Australia, less than 1%, mostly less than 0.5% of all deaths are through voluntary assisted dying at this stage. So it's a tiny minority of people who are using this. Let's allow those people to have this comfort when otherwise it would be denied to them.
Or as they say, no extra death, but a lot less suffering. Speaking of conscientious objectors, what's your view then on the aged care sector and homes, especially those of religious persuasion, being allowed to opt out when they're actually people's homes, and it should be their right to end their days in their new home as they see fit?
I struggle with the difference between individuals who I believe should be allowed the right to conscientiously object and institutions, particularly if they are subject to public funding, being able to do the same. I'm glad to say many of the aged care facilities that I've talked to and worked with are beginning to move in their view about this, even in the Catholic sector. So I think there's always room for conversation about this. I don't think it's fixed. And while I don't think it's ideal that they should have that option, I think as we're moving through this process, we're finding more and more people are coming on board.
I'd also like to point out that I've recently struck up conversations with Mr. Ian Wood. Now, Ian was the recipient of the 2024 Rodney Syme Award for his services both locally and globally to the voluntary assisted dying movement. He founded an outfit called Christians who support choice in voluntary assisted dying. And he pointed out to me that at least 75% of people who identify as Christian support it as a compassionate choice for others, even if they don't choose it for themselves. And that 78% of those identified as Catholic. So I sometimes think it's a case of the leadership in both the church and in Canberra politically not being in touch with what the majority of people want, yeah?
And in my experience, again, when I talk to individuals who work in these institutions, then overwhelmingly the majority are supportive. One of the problems is they're getting a lot of their instructions from the higher powers, shall we say, who are a little bit more fixed in their views.
Okay, well, it is good to see a lot of these conversations coming into public discourse, including last night on the SBS Insight program. I encourage everybody to watch that if they're interested in the subject matter, in which the President of New South Wales, Dying with Dignity, Penny Hackett, very eloquently answered the question in relation to coercion and some of the disability concerns that people had. And she did a terrific job of putting some of the misinformation straight, as you have done today, Dr. Carr. So thank you very much for your time today, Nick.
Oh, Suzanne, thank you. And thank you for your continued advocacy in this such an important area.
That was Dr. Nick Carr, VAD specialist on the board of Dying with Dignity Victoria, helping us dispel some of the myths and misconceptions around voluntary assisted dying. My name's Suzanne James. Thank you for joining us.